For those of you who have decided to join us live, you're in for a treat for reasons that I just learned from Dr. Ravi, but for reasons that were really, really precious to begin with. And I'll share the background a little bit. CPS has been a venture in the realm of medical education, and when people think that, it's natural to assume that most people who consume and are part of this work are learners who are learning, and that was true for a very, very long time. Uh, as you all will inevitably see, once you become a neutrophil or a red blood cell, you lose your ability to remain pluripotent and want to learn general medicine, and that is true for almost all attendings. The exceptions are here before you. And the very first exception is our beloved Dr. Ravi, who has been a legendary attending in the realm of CPS, who his enthusiasm for medicine is hungrier than the average MS3. And equally impressive in that domain is my co-discussant Jeffrey. And so I am so excited to share the stage with both of them today, in large part because it represents the slow breaking of the norm. I think of the norm that the attending is less and less interested in the dissection of the clinical reasoning. And so I'm really, really excited. It's Jeffrey's first discussion in a situation where the case isn't guaranteed to be rheumatologic. So he's taken a special gamble today. And so I'll hand the mic to you, Jeffrey, just to say hello and maybe reintroduce yourself to the folks who hop on Thursday.
Hey everyone, I'm Jeffrey. I'm one of the rheumatologists at Duke. I've been interested in clinical problem solvers for a really long time. My interest in rheumatology is in improving clinical diagnosis for people with sarcoid and as well as the interlap between central nervous system diseases and rheumatology. And super excited today to co-discuss with Robbie and feel very comfortable that he's here to help me just in case, there's this non-rheumatologic component that and excited to learn with all of you. Thanks so much.
Absolutely. The pleasure is all ours, my friend. Before we hand the mic to Ravi to say hello and kick it off, let's just make sure we honor the folks who are making this happen, our beloved CP Solvers Academy members. First up is Sarah, who's scribing today. Mic to you, Sarah.
Can you hear me now? Okay.
Yes, we can.
Hey.
Hey.
Hi, I'm Sarah. I am a fourth year medical student at Emory, applying neurology, but I do love medicine. A big fan of clinical problem solvers and happy to be here.
Amazing. Happy to have you. Maybe we'll have a neuro element to this case that we'll lean on you for. Alrighty, and now Mike to another CP Solvers legend who needs no introduction, quite frankly. For those of you who don't know Anmol Preet, you should hang out with us longer and longer. That's all I'll say. Mike to you, Anmol.
Hello everyone, I'm Anmol Preet, medical graduate from India, applying to internal medicine this year. Just trying to recapitulate how Sarah introduced herself. And I'm very excited for today's session. I'm looking forward to the case.
Anmol, I'm confused and disoriented. You didn't do your good morning, good evening, good afternoon routine. I don't know what to do now. I have to recalibrate. But thankfully, we have a familiar voice in Dr. Ravi to hand the mic to.
Hello, good evening, everybody. Thank you for coming on. Really excited to present this case to Jeffrey and Robbie, a unknown, and definitely will be eager to see what kind of thoughts they have regarding this case. So very excited.
Thank you, Ravi. Thank you for anchoring this week in terms of case presentations and continuing to innovate in different ways with presenting a case that is still a little bit of a mystery. And so we're excited to reflect on it. Alrighty. Take it away, Ravi, whenever you're ready.
Okay, so the chief complaint is a 19-year-old woman who's had recurrent oral ulcers for over about 5 years. I'll stop there for discussion.
Jeffrey, I think you're very well suited to take this, my friend.
All right, well, I guess I'll just begin by sharing my approach, and I'm curious to what Robbie's approach is to just thinking of oral ulcers. So, oral ulcers can be very common, and aphthous ulcers are thought, I think like in 15 up to 15-20% of the population, you can have aphthous ulcers and it can be recurrent up to, 3 or 4 times per year. So, part of my, the next part of the history I'm trying to figure out is this just, something like a common problem that we're dealing with, or is there's a more insidious process that we have to be starting to be worried about? And some of the features that I would look for to be worried about that is what the appearance of the ulcers are like. Are they deep? And are any necrosis? Do they heal after 2 weeks like a normal aphthous ulcer does, or does it persist? And there's this concept that if you continue to have ulcers such that before the ulcers heal, you get another set of ulcers, that's another sign of maybe there's something more than just aphthous ulcers are going on. And then, the last part of the picture is, is there anything systemic going on in the rest of the body while this patient is having recurrent oral ulcers? So those are my preliminary thoughts. Curious to see what Robbie thinks through this.
I'm right there with you. I think that I'm really eager to hear that information, and I think we'll lean on you to analyze the zoomed in detail. I think the big picture is the beautiful occurrence of the word recurrent, which sure sounds a lot like rheumatology, and I think that that's true because anytime that something recurs, uh, well, maybe I should set it up this way. I think if you take the simple formulation that diseases are either problems that come from the outside of the body and invade it, be it infections, drugs, toxins, allergies, or conditions that arise from within, such as cancers and autoimmune diseases. Whenever you have recurrence, you wonder, of course, about the possibility of recurrent exposures. And a great example of that would be that somebody has recurrent HSV from an exposure that continues to reactivate. But I think most of the time, whenever something quote unquote flares or recurs, these are words that are very evocative of autoimmunity. And I think the diligence that you want to try to do now is to make sure that you're not skipping over some exposures that tend to recur, like infections or toxins. But if there is little to no fingerprint of an exogenous disease, most of the time something recurs. It is because the body periodically attacks itself. I think you have to be careful because I think when we assume that the patient recurs, in our mind, we make the cognitive assumption that the same thing happened again and no cumulative disability occurred. It's very different when a patient has recurrence of a disease, but in the meantime has built up a whole lot of consequences. So there are malignancies, for example, that come in waves. The Pell-Epstein fever of Hodgkin's lymphoma is a great example of that. But in the meantime, as an aspect of the disease is occurring, the patient is piling on complications. And so what I'm inclined to study here is just as Jeffrey said, the nature of the disease, but I'm really inclined to scrutinize the word recurrent. And isn't recurrent cumulative or recurrent without more cumulative morbidity? And if it is recurrent without cumulative morbidity, there are very few things that do that. Except autoimmune disease. And I'm using the word autoimmune disease here to lump in acquired autoimmunity, congenital autoimmunity, autoinflammatory, just as a broad term. And so I'm really excited to hear from Rabih of what has happened over the 5 years. Is it just the ulcers, or has something else happened? And I'll leave it finally at saying it's helpful to think of autoimmunity as autoimmunity, localized. And there are many localized autoimmune diseases like aphthous ulcerations. Or whether they are systemic. So those are the two questions on my mind: is study everything that Jeffrey said about the nature of the ulcer, but study the word recurrent as well, and try to fit it into purely recurrent versus recurrent cumulative, and also recurrent and isolated versus recurrent and systemic. And I think that an analysis of the word recurrence merged with Jeffrey's analysis of the ulcers will help us make a lot of progress. All right, Ravi, Mike, to you.
Wow, amazing analysis of just this 3 words that I just mentioned with the recurrent oral ulcers. So a little bit more background. So this 19-year-old woman who's had these ulcers for 5 years, and during this time, she's only had short ulcer-free intervals that were lasting a few months. Going back 7 years, the only other history was idiopathic urticaria, which was challenging to manage. Allergy testing revealed sensitivities to walnuts, pecans, eggs, tree pollens, and mild lactose intolerance. Despite dietary elimination and antihistamine, she continued to experience periodic urticaria. Around 14 years of age, she developed the first oral ulcer on the tip of her tongue. This lasted about 2 weeks, followed by a recurrent lip ulcer that persisted for 4 months. At one point, a thought of metal allergy to braces was considered. The braces were removed, but the symptoms didn't improve at that time. And then a few years after, there were 2 large non-healing tongue ulcers. And along with this, she developed severe neuropathic tongue pain, which was also associated with neck spasms. Recently, there was another ulcer on the tip of the tongue with tissue loss. And during this time, associated symptoms over a period of time that manifested were lightheadedness, arthralgias in the knees and wrists, alopecia, ear pain, headaches, lymphadenopathy, shortness of breath, intermittent digital cyanosis, fatigue, pruritus with occasional hives, nausea, and possible irritable bowel syndrome-like symptoms. These systemic features do flare with ulcer recurrence. During this time, she was on a varied treatment regimen: steroids, colchicine, Valtrex for possible HSV. Nothing has worked so far. I'm going to stop there for discussion.
Jeffrey, I think you know how it goes when I'm with the learner on Thursdays. I usually have them take a crack at it, but I think that is not fitting for you. So maybe we should alternate, and I'll just take a crack at the sort of analysis that I was thinking of with regards to the word recurrence, and then pass the mic to you for everything else. And I think the question of have we had cumulative consequences? I think the answer is yes. We've had persistent tongue loss. We've had limitation in exercise capacity, and we seem to have joint residual ongoing joint disease. But although that hasn't been confirmed by physical exam detecting synovitis, but I think this isn't a purely episodic disease. This is accumulating consequence after consequence after consequence. And unfortunately, the consequences seem to be occurring at a more ferocious and intense pace. Um, you can see, though, how that the initial attempt to label this as a pure episodic disease, to study exogenous triggers like HSV and allergies, was probably an attempt when the disease was more gentle, but probably not a significant amount of cognitive energy. And I think the progress that we've made by seeing all these features evolve over such a long period of time is to make the very reasonable conclusion now this is a problem from within. And I think the nature of that problem from within is probably going to be clarified by studying the fingerprint of the disease. But an exogenous trigger of a long-standing, recurrent, progressive disease is fairly unusual. And so, in summary, I'm really glad that Jeffrey's here because I think there is no one better suited to analyze these specific symptoms. Mike, to you, Jeffrey.
Awesome. Wow. This is already an incredible story that we're getting. And I'm also so glad that I have Rabih here with me to just think of all the other possibilities that could be going on here. I feel like whenever you have so many different symptoms involved, one of the major challenges is to distinguish what is signal from what is noise. And this is especially true because a lot of times when we're trying to understand what's going on with the patient, we tend to do a pretty comprehensive review of systems just to be very thorough. And while we do that, especially in the initial stage, as we're just getting to know the patient, we get all the information and they give us all the information, but we haven't had time yet to explore who they are, understand what is normal for them, what is not normal for them. So we're getting a lot of symptoms here, and a lot of them are non-specific, but some of them are a little bit more concerning than others to point towards a kind of a more concerning etiology for the ulcers. So the one that, Robbie mentioned, which is just the fact that they're non-healing, and now we're actually having basically scarring or damage from the ulcers on the tongue. So that's one red flag. Other ones are the fact that there's lymphadenopathy, which is a little bit strange if you're just having oral ulcers, unless the lymphadenopathy is just regional, mild, and only occurs during the flares. But if there's lymphadenopathy anywhere else, if it's tender, if it's persistent, the fact that there's shortness of breath, and these kinds of symptoms we don't usually see in non-systemic versions of aphthous ulcers. I will say that, we have a dermatologist at Duke who we rely on a lot. She's really an amazing immunodermatologist. And what she has taught me is that actually when recurrent aphthous ulcers are really bad, in dermatology, there's a disease, they call it aphthous ulcer major. You can actually have systemic symptoms just from the degree of inflammation. That includes low-grade fevers, arthralgia, and myalgia. But it shouldn't also include things like shortness of breath and lymphadenopathy. So I think those are kind of the things that are pulling me away, that this is not just a kind of a severe form of recurrent aphthous ulcers. But then after that, it's hard to know what are the things that are relevant towards the things that are that may be more non-specific. So I guess the first review of this, I'm just gonna at first just assume that everything is relevant and can be unified into one diagnosis. So just from a perspective of a rheumatology provider, there actually are some conditions that can unify all of these things. And I'd be curious to see on further testing, on further questions on further questions you ask them on history, as well as the exam, do they correlate? So I think the first important one that is a common disease that we consider that can cause a lot of manifestations in ulcers is lupus. She is in, sort of the right age range, and lupus can cause, mucocutaneous ulcers, although almost always they are painless. But it can sometimes be painful, and it can also be for two reasons. One, due to the different type of lupus that affects the mucosa, and number two, due to superinfection. And all these other symptoms, including alopecia, headaches, lymphadenopathy, arthralgia, even the digital cyanosis and fatigue, and shortness of breath, all of these can be seen in conditions such as lupus because of how multisystemic that disease is. So if I go through from like more common rheumatologic disease to less common, lupus is the first one to look at, and that we can just test with an ANA and do a physical exam to see if it's consistent. Now, going for less common causes, there are also less common causes that, I see multiple people in the chat talk about. So the next one that comes to mind is something called Behçet's. We talk about Behçet's a lot in rheumatology. It actually is very rare to have Behçet's. But it is something that that prominently causes mucocutaneous ulcerations, arthralgia, this whole entire systemic profile. And this presentation could fit very well with that as well. So that's another one that I look for. The thing that I'll be trying to look for is, does the patient also have evidence of genital ulceration or not? And then in the other autoimmune bucket that's not in rheumatology, but it's actually in GI, there's a set of autoimmune diseases there that can cause oral ulcerations as well as systemic symptoms. So the first one is inflammatory bowel disease. So both Crohn's and then less likely ulcerative colitis can have systemic manifestations. And Crohn's is more likely to, well, Crohn's affecting the upper, mucosa, the oral Crohn's can cause oral ulcers. Although I've also seen ulcerative colitis present with a superinfection in the mouth, such as from HSV or a different type of infection, and you can have both at the same time. Now, in that IBD category, there's rare mimics of that as well. For example, you can have GI histoplasmosis, GI sarcoidosis, other things that mimic inflammatory bowel disease, but that's like kind of one category of diseases. And another category of diseases in the GI realm to think about is the celiac disease spectrum, which also can have a lot of these different systemic features, as well as oral ulcers as part of the main kind of picture that they present with. So we talk about rheumatologic and GI. The last one that's important to talk about is actually primary dermatologic diseases. So if we think that these other parts, these other features like the headaches, lymphadenopathy are a little bit more nonspecific, and if the patient actually has a rash, which we're not hearing about, autoimmune blistering diseases, so the most common being pemphigus vulgaris, but there are a lot of different ones. For example, epidermolysis bullosa, so they're rare ones as well. Those can be considered. And so if we're, getting the original lab work exam and we're not getting much out of it, that's one thing that we also need to identify to make sure that's not what's going on. So those are kind of the three major autoimmune categories. And then there's also, as Robbie mentioned, things that cause recurrent oral ulcers or recurrent symptoms, infections, and even maybe less likely, but possible types of cancers that can do this. I think at this point, we'll probably put those two categories as well as a lot of actually autoinflammatory diseases that can cause that a little bit less likely for now until we evaluate those primary etiologies first. So that's what I have for right now.
Wonderful analysis there, both Robbie and Jeffrey. Yeah, everything that I could think of for this case, I think you pretty much covered. Moving on to exam, there's really rolling back to family history. Nothing like this in the family. Going back to exam, vital signs are normal, afebrile, BMI 21, patient is well developed, and the only abnormality, skin, no rashes, no cardiovascular, pulmonary, no genital issue, no genital ulcerations, no external GI abnormalities, nothing there, just the lesions in the mouth. I'm going to share screen for a moment for this aliquot, just to show the ulcers over a period of 4 years. Here we go, 4 or 5 years. So starting at the top, so the first ulcer you see, I think, is back in 2020 on the top of the tongue and then the lip. And there's one at the bottom of the lip in 2021 here and 2024. So these are in all sorts of recovery. I think there was a biopsy done, and I'll reveal the results of the biopsy in a bit, in the next aliquot. And so some of these were healing and non-healing or taking a long time to heal. And I'll stop there. And they're very painful as well.
Yeah, Roy, I mean, these are very attention-grabbing ulcers. They seem horrible and extremely painful. I find it very fascinating to see that, like, when you're trying to, you use your ears, and you're using your ears and listening to this narrative presented so well by you, you panic. And the question is, how much of that history would you have predicted based on what you're seeing in front of you? And based on your physical exam, the only aspect of the history that seems to have an ongoing imprint on the physical exam seems to be the ulcers. And so the question in my mind is, as we try to catch the perpetrator that's afflicting this patient so much, I think our best chance is to catch it doing what it has been doing to the patient right now. And I find it fascinating that so much of the historical aspects of the disease are not here right now. There is no lymphadenopathy. There is no cardiopulmonary disease to suggest shortness of breath. There is no cyanosis of the skin. And so what does that mean? Does that mean that there's some element of this disease that's tempered by the treatment that she's received with the steroids and colchicine? Or does that mean that this is a periodic, chaotic disease that comes and goes and comes and goes? And it just so happens that the autoinflammatory diseases or the periodic fever syndromes are notorious for their effects on the oral mucosa. So could this just be that this disease has been tempered by what we have done, or is it because this is how this disease behaves? Is a really interesting frame to take. I think if I were to summarize everything we've heard so far, most of the symptoms that we've heard so far and the findings we're seeing are surface symptoms. Surface lymphadenopathy, surface ulceration, surface cyanosis, surface hair loss. And I think a question on my mind is how much internal organ devastation has happened? Is there hepatic involvement, hematological involvement, renal involvement? And I think an inventory of those organs will be very, very telling. And either they will represent a clue to the underlying disease, be it both in the signature that they exhibit or the absence of systemic disease, which is a profound clue to the underlying disease. Or we may have to settle with being distracted by the condition that was presented today by VJ, AA amyloidosis. And if we do see evidence of AA amyloidosis on this patient, that'll give us a really profound insight into how hectic and severe this inflammatory process is. So my observations to layer on so far is it's curious that there is only the lip scars to prove that disease has existed. And now I'm interested to see and open the door into the depth of the visceral organs, which we have yet to inventory to help us make progress. What about you, Jeffrey? Where are you at?
Yeah, I think I'm right along there with you. I'm curious as to whether some of her disease is intermittent or part of it is more easily treatable than the other, and the gist of how kind of prominent the oral mucosal symptoms are relative to a lot of the other symptoms at this point on the exam, as well as the patient's complaints. I think I lean still a little bit closer to a dermatologic GI cause first before looking at a rheumatologic cause, mainly because I think right now what I'm seeing is I'm trying to, figure out where the center of gravity for this case is. And it seems like it's still mostly focused kind of in the oral mucosa. And I'm wondering if this is just so severe that a lot of the other symptoms are just being caused by the inflammation there. So that's what I'm thinking of so far. I'm curious to hear what happens next.
I want to show you all. I think so far this disease is as elusive as my dog is trying to be. He's trying to hide under this trunk, but he is doing an absolutely abysmal job at hiding. It's very apparent. So I hope that the next set of data will be as revealing as his attempt to camouflage himself. But Mike, to you, Rabih.
I'll move on to the lab. So I think some of this will help move some of the thoughts aside to hopefully get to somewhat of a narrow differential. So essentially the CBC white count is 11. Neutrophils were predominant. This is the latest data I have. Hemoglobin 12.3, platelets 245. So nothing remarkable there. And CMP, essentially everything's normal. Just to cut to the chase. Liver enzymes are normal, kidneys normal. The electrolytes are normal. And then I'll move to specialized testing. I'll give you some information on inflammatory markers. So SED rate 36, CRP less than 1. And to give the first bunch of autoimmune panel workup, ANA, the indirect immunofluorescence assay was negative, anti-DNA double-stranded negative, RMP antibodies negative, Smith antibodies negative, anti-scleroderma 70 antibodies negative, anti-SSA, anti-SSB negative, anti-chromatin antibodies negative, anti-EO1 negative, anti-centromere B antibodies negative, ANCA panel negative, rheumatoid factor negative, thyroid panel negative, fecal calprotectin normal, tissue transglutaminase IgA normal. And I'll stop there.
Take it away, Jeffrey. What are you thinking?
All right. I guess I'll start with this one just because of the rheumatology panel. So I'm actually glad that all those antibodies are negative because I would be a little bit more confused if some of them were randomly positive. Because again, I'm not sure I have enough of a flavor to really say that this is, even with the positive autoantibodies, this would be enough to diagnose lupus just because of how prominent the mucosal features are. Now, out of the rheumatologic diseases that can have such a strong component in the mouth causing these mucosal ulcers, really, Behçet's is essentially the main one that causes it. And in addition to Behçet's, rarely you can invoke any vasculitis that somehow affects the tongue. Although I've only seen this in the case of giant cell arteritis, and this patient is much too young for giant cell arteritis. So what I'm looking for, I guess, right now is, am I thinking of this correctly? And the main area of the inflammation is really in this mucosal area. And we're having kind of other areas in the body affected that are more from the constitutional symptoms from inflammation. And if I look at the symptoms again on the review of symptoms, what we have is alopecia, ear pain, headaches, lymphadenopathy are all kind of in a region that are very close to where these oral ulcers are. The IBS-like symptoms is in a different location, being in the stomach, but I guess can be connected through the GI tract. And then I wonder, are the arthralgias, the fatigue, part of the constitutional symptoms? And if this is the right approach of looking at it, where I would go next is probably getting tissue and vascular imaging to see if are we missing something that's causing a ischemia to the tongue that's also causing vasculitis somewhere else that we can see on imaging. And number two, what is actually going on in the oral ulcers? Are we missing, for example, a rare infection that we don't understand? Or is this chronic EBV, which can very rarely occur in people with very rare immunodeficiencies? What is kind of going on in the oral ulcers that are so prominent? So I think that's where the focus of my attention is going to be at this point. But I'm very curious to hear what Rabih thinks as well.
Yeah, no, I'm right there with you. I think we're still trying to answer the question, is this a localized phenomenon limited to the mucocutaneous surface, or is there a systemic disease with prominent mucocutaneous features? And I think the labs are one way of analyzing that, and I think the imaging would be another. So if we learn that there is aortic thickening or a large spleen or diffuse lymphadenopathy, I think that would change the calculus. And so, yeah, I think the only progress I've made is I think that the disease is very likely from within, and we definitely have very prominent localized features mucocutaneously. There doesn't seem to be any laboratory evidence of systemic disease, and I think the only open bucket left to fully understand the problem is to see if there's a radiographic imprint, be it vascular or organ manifestations that are better assessed radiographically, such as the reticuloendothelial system. So yeah, I'm really curious to understand histologically what's happening in the ulcers, and then radiographically what's happening in the body. And I think when we see that we can, when we get those things, we'll have our equation to finally put into your large brain, Jeffrey.
Okay, I have about two, maybe three aliquots, but the biopsy, so the several biopsies that were done of the different lesions, I'll kind of put them together. So one biopsy showed ulcerative granuloma with stromal eosinophilia, what's known as TUGSE, TUGSE. And there, in one of them, the inflammatory component, there was, again, eosinophils scattered neutrophils, few lymphocytes with CD20 and CD3 immunostains. Abundant histiocytes highlighted by CD163 stain. Prominent vessels of the granulation tissue are highlighted by CD31 stain. And EBER-ISH was also performed and was negative. So basically, granulomas with traumatic ulceration, what's known as TUGSI in various lesions, with a lot of different mixed inflammatory cells. I'm just looking, anything else? No infection. And all sorts of healing, hyperplasia, hyperkeratosis happening at the same time as well. And I'll stop there.
Yeah, I think, Jeffrey, I'm finding myself at a significant knowledge gap to really get as much juice out of this histological finding as possible, though I'm glad to see that there doesn't seem to be evidence of small vessel vasculitis. And I think that the presence of granulomas is certainly very interesting. And I think um, for me, it just triggers the space of wondering whether this is a systemic granulomatous disease, and that confidence will be markedly augmented if we see internal organ manifestations evocative of granulomatous disease. But for me, I think the main granulomatous disease I imagine ulcerates in the mouth is Crohn's disease. And wondering if this is a very aggressive version of the same, though the counter arguments to that would be the powerful negative predictive power of the fecal calprotectin, which is almost 100%, though not quite. Um, of course, there are many other granulomatous diseases, including granulomatous vasculitides, like giant cell arteritis, GPA, EGPA, so on and so forth, and even sarcoid, your favorite. Well, I don't know if it's your favorite, but a disease I associate strongly with you. Um, so yeah, I think the lack of neutrophils is interesting here because I think one might have expected neutrophilia to be a prominent momentum provider to the diagnoses of Behçet's and the family of periodic fever syndromes, like the one you taught me about, FAFA or something like that. So the lack of neutrophilia, I think, is telling, and the presence of granulomas is intriguing. And I'm now primed to study the visceral imprint of this disease more from a reticuloendothelial perspective, um, and a vasculitic perspective than anything else. What are you making of it?
Yeah, so this is a really challenging conundrum, I guess, that we have here. You know, Tugsy, what they're reporting on the biopsy is essentially saying that the ulcers there, so the granulomatous and eosinophilic infiltration, and I don't have a great understanding of, of how they can tell on the pathology, but it's almost like saying that it's secondary to some type of traumatic cause for the condition. So that by itself really doesn't explain at all any of the findings that we're seeing here, like why are there recurrent ulcers? Why is it so bad that it's causing permanent scarring? So I'm wondering if the biopsy may just be catching a part that is non-specific. So I'm not completely sure what to make of the granulomas and eosinophils there. One part of me says that there's a potential we are just not catching the right finding. The other part of me is saying, well, if it is the right finding, what could cause both of those to be there? So whenever I see both eosinophils and granulomas in the same area, there are a couple of things that come to mind. So EGPA, which is eosinophilic granulomatosis with polyangiitis, is probably the first thing because it has both words in the same in the biopsy and also in the diagnosis. So EGPA can cause, if it was causing vasculitis or granulomatosis deposition there, I think it would be possible. Usually the patients with EGPA, almost all of them have a history of asthma and other kind of allergy related conditions. I know we have a history of urticaria. I'm curious if the patient also has other manifestations like asthma or other things like that. Certainly not the most common presentation, but it's something to think about. and 50% of those cases can be ANCA negative. So that's definitely one thing, the first thing that goes to mind. The second, a couple things that come to mind are sarcoidosis can certainly cause granulomas, and the eosinophils there, I'm not sure if they may be, for example, bystanders there, which can rarely happen in sarcoidosis. So you may have non-casein granulomas, but I think it would just be strange for oral sarcoidosis to cause this prominence of symptoms to the point where you have non-healing ulcers. Usually when you have the granulomatous ulceration with there, it's accompanied by ulcers also on the outside of the mouth, kind of with the cheilitis. And it can be recurrent, but I'm not aware that it can cause this prominent of symptoms. And usually the syndrome of the sarcoid in the mouth is called something called Melkerson-Rosenthal syndrome. So that is something that we can keep in mind. Maybe that is a possibility to consider. The other thing that comes to mind is histiocytic disorders. So they're called sometimes eosinophilic granulomatous disorders. And the main one in this age group would be Langerhans cell histiocytosis. So I'd be curious if and these histiocytic disorders are extremely difficult to diagnose in my experience, like often requiring 3 or 4 biopsies in different locations before finding the actual area that actually shows the histiocytic disorder. So I'm curious, you mentioned that CD163 stain was positive, meaning histiocytes are there. Sometimes the pathologist can look at them and tell, like, are they atypical appearing? Is there any other morphology that makes you think it could be that? Um, so those are, and then the final thing is drug-induced reaction. So if it was some type of reaction to something like something that she's eating, like a food or some type of medication or something that she's swishing in her mouth. Like, oftentimes with people with recurrent oral ulcerations, will put stuff in their mouth and swish it because it's so painful. Could she be having a drug
Do you
reaction
need
to that, and
chargers?
that's causing the
I'm in
eosinophils?
charge.
You're in charge.
Mhm.
So, like, whenever such messages
So,
come, does it mean patient has already hit the floor?
Kirtan, I think that you're unmuted for some
Because
reason.
this is
No,
not.
that means they will.
But yeah, those are what my thoughts are so far, and curious to hear what the next part of this is.
Great discussion so far, Jeffrey and Robbie. Yeah, a lot of great analysis and in-depth, evaluation of what is going on. Yeah, I don't have a final DX, but I have 2 more studies. So yeah, nothing imaging wise, systemic wise, nothing apparently is showing up. No involvement of spleen or reticuloendothelial system. Looking at the GI tract, I know you're talking about Crohn's disease, ulcerative colitis. So a full GI workup was done, and including capsule endoscopy, EGD, and colonoscopy, biopsies, everything was negative. The only findings were mild gastritis, H. pylori negative, but nothing at all found. And I guess Behcet's was in the differential, and next generation sequencing was performed, and this will be the last aliquot. And the patient turned up HLA-B51 positive. What was interesting, what Jeffrey had mentioned, and I like to ask Robbie and Jeffrey, like with this, like how far can you push a preliminary diagnosis like of Behcet's? Because like you mentioned, this doesn't kind of fit the picture, right?
Jeffrey, I think you're up, but I just wanted to share with you all, when you look back at that last aliquot, you're seeing the difference between analogical reasoning, which is what I did, because I have no expertise in the domain of tongue biopsies or analysis. So I was like, what does granuloma mean? What do the eosinophils mean? And using just knowledge of diseases I'm more familiar with. But then you heard what expertise does. And what Jeffrey did expertly was like, hey, I'm not sure what the significance of these things are. Should our attention be instead paid to the histiocytic abnormalities? And I think that's the journey I think we're all on. We all use analogical reasoning when we're less familiar with things, and then hopefully each of us is developing expertise in the path that we're inclined to go in. Jeffrey's expertise was on display there, and I think it'll be handy to analyze this specific question. Um, I can offer the analysis of the like large uh, picture, which is unfortunately uh, this I can only imagine what it's like to suffer this much, let alone at such formative years in your life where you have such debilitating symptoms. Especially symptoms that are so prominent, so visible, and so disabling. Um, in parallel, those of us who spend a lot of time in medicine know how much worse it could be. With this patient, the patient that we were discussing this morning, for example, was of similar age, if my memory serves me correctly, or maybe slightly older, who had spleen go down, liver go down, kidney go down. Um, and so whatever this disease is, it's really, really um, geographically contained to the surface. And what that likely will mean for the patient is, I think, more diagnostic ambiguity and more uncertainty, but counterintuitively, a more gentle prognosis than the patient we discussed this morning, for example. The untreated prognosis of the patient we discussed this morning is through the roof. The untreated prognosis of this patient seems to be much less because of the essentially near perfection of the internal organs. And so I think the tension you're seeing if you're watching both cases today is when the viscera is involved, the prognosis plummets, but the diagnostic specificity and ability to mount specific tests skyrockets. So if we heard from Dr. Ravi that this patient has hyolymphadenopathy and nodules in a lymphatic distribution, morbidity skyrockets because now we have visceral disease, but diagnostic ambiguity plummets to sarcoid. And similarly, if we had heard the patient has genital ulcers and has GI tract involvement and has rhomboencephalitis, morbidity skyrockets, but diagnostic specificity increases. So I really, really feel for this patient because I sense that any diagnosis we render now will be a stretch assignment, in large part because the disease really seems to be contained to one organ, and that organ seems to be the skin and the mucosa. It's a shame that that organ is so widespread, literally from head to toe, but it is one organ nonetheless, and so visible, I must add, socially too. So I'm pontificating philosophically on the challenges before us, but maybe Jeffrey can enlighten us on this specific test.
Yeah, I think this is such a challenging case, but really good one to think through. Um, so yeah, I guess to kind of go through the question of does the HLA-B51 here, how significant is that? Does that actually lead us to a diagnosis? I think that the problem with, relying on where my instinct is that if we were to, use that as a way and, be very excited and be like, yes, we finally got an answer, I would just be a little bit cautious because I feel like a lot of the mistakes that I've made in the past in clinical reasoning have been the over-reliance on a test when, especially in the setting of where you've tried so hard to figure out what's going on and then finally something comes back positive. And for me, it's like usually like, oh, it's like the EBV is now the positive in the blood, and then ID's like, yeah, that's like 2 copies. That has nothing to do with what's going on. So it's just it's something that's instinctive because we're trying so hard, we really want to know the answer. But I think of this, if we really think about this, Behçet's is something to think of, but we still just don't have enough to really make the diagnosis. And although, how this is an uncomfortable place to be in, the place where we have a lot of problems going on that are, interfering with her ability to function, interfering with her life, interfering with her ability to go to school or even work, and we want a diagnosis, I think that at this point, I think we have to stay and be okay with the discomfort of not having a diagnosis yet, while still trying to find ways to, number one, further investigations to understand that it's disease, and second, try things that we haven't tried before in terms of treatment if they seem reasonable for the patient that may benefit them. So I don't think that we have enough here yet to call this Behçet's disease. And at this point, some of the thoughts that I would have one, seeing a dermatology specialist, someone who specializes specifically on autoimmune blistering diseases or oral mucosal diseases, who will probably have seen some cases like this before because they see a lot of oral pemphigus vulgaris. And just hearing what their thoughts are and what their next steps would be as well. A second thing is if we really wanted to answer the question of could this be, vascular in origin, we can get vascular studies of the head neck region just to help us answer that question. And I think the third is going into the rare possibilities, uh, making sure that this is not an immunodeficiency that has a very rare presentation because a lot of them can have overlap with autoimmune syndromes. So that would be essentially seeing an immunologist, getting things like serum immunoglobulins. Robbie mentioned PFAPA, so there's autoinflammatory diseases that usually don't cause this extensive amount of mucosal ulceration, but certainly also thinking about immunodeficiencies. I think someone mentioned like haploinsufficiency of A20, which also shouldn't typically cause this extensive ulcerations, but I think that can lead us to making sure that we're going through the appropriate investigations. And then in terms of treatments that we could try, if they haven't been tried already, I think it is reasonable at this point. Is it seems kind of autoinflammatory in its nature that we can try other things such as dapsone, such as other DMARDs, even TNF inhibitors, which would work for both Crohn's disease, sarcoidosis, granulomatous disease, most granulomatous diseases, almost of any cause, um, would benefit from a TNF inhibitor, except for an infection. And so I think those are all reasonable things to consider at this point. But yeah, thanks so much for bringing this case. And back to Robbie to see if there's any final thoughts from his side.
No, nada whatsoever. I think that was superb, Jeffrey. I'm curious what Ravi has to share.
Yeah, so absolutely wonderful discussion, and I'm glad Jeffrey and Ravi, you didn't just anchor on that HLA test, because a lot of the history of this case is that that was like the smoking gun. Like this finally is something to hang your thinking cap on. But as of current, a Behçet's expert says this is not Behçet's, but this could be possibly IBD associated. However, the testing is negative, right? Robbie mentioned fecal calprotectin, very good test, but negative. The examination of the GI tract has been negative apart from the oral mucosa, but you can have an anomaly. So I did a search. So you can have nothing in the lower GI tract and upper GI tract, but just this. And with the granulomas, that may be something. But yeah, Jeffrey, I agree. Trying, because the usual steroids and everything has not worked, maybe it's time to start one of the next level medications, so DMARDs and so on, probably is in the pipeline, and we'll see if that responds. But a very troubling case. But I think the journey, both of you have shed enormous light on this journey. I do really appreciate all of your wisdom for this case, allowing me to bring this case, and also for your kind words, because this person's been through a lot. It is very painful. There's a lot of suffering, and it's just very harmful to hear about people suffering in this manner. Thank you again.
Oh, the thanks is all to you, I think, Ravi. We have the privilege of enjoying stories that are fully told, and I think most stories in our real life are not fully told or incorrectly told, and so getting that exposure today is I think powerful, and I think it's also just so nice to celebrate the presence of expertise here. I think in my life I found it hard to watch experts struggle with the fact that they should be experts, which means that they should know, quote, everything. And then to see an expert before us demonstrate the humility and the uncertainty that exists in our world. And so I think, Jeffrey, you stand in great contradistinction to the biggest fallacy of expertise, which is the illusion of know-it-all. And I think you were reiterating that this is not knowable, I think is it really does justice to the patient and doesn't close the book on her journey prematurely and continues to respect the fact that we don't know. And I really, really admire that. Any final words and reflections to you before we get a recap of the journey from Unroll?
No, thanks so much for your incredibly kind words. Yeah, I mean, I feel so sorry for, how much this patient has gone through, and, I'm hoping for the best and that we'll eventually find an answer. And I think one final reflection I have is that, journey as a rheumatologist is that oftentimes, even when I bring cases, we get to see the evolution of the case, and just by walking the path with the patient, we get to see kind of the whole entire journey and at the end diagnosis. And along that, a lot of it is just walking and being there and seeing how the case unfolds. So definitely, this is not something that is always easy. But I think it's important for us and with our patients to know that, we're on this journey together and we'll be with them. And, when things come up, we'll, try to work on it and figure out what's going on. And I think in rheumatology, that's something that we do a lot. And I hope that this patient gets the care like that.
Very well said. All right, Anmol, mic to you.
Thank you so much for the great case. I got a lot to learn, and there was a lot of potential discussions. I think these cases are important because so many times I reflect back on these cases, and then so many new ideas come up. The main essential idea of treating the patients, it goes well. So I'll just start with the chief complaint, which was oral ulcers. So whenever we have a complaint like this, like a rash or an ulcer, we look for we look at what's the appearance of that, what is the depth, if it heals or it persists, and if there are any areas of necrosis which are seen. Then importantly, when we have a localized oral ulcer, we have to see if there are systemic features too. Some of the common oral ulcers we know are aphthous ulcers, and they are known to recur. This patient had recurrent oral ulcers, so it was important to look for any recurrent exposures like infections or toxins which could lead to this presentation, and potential removal of those can help this patient. So we discussed that some conditions can come in waves, just like recurrence. Some conditions can do that, just like pale Epstein fever and Hodgkin's lymphoma. And whenever something is recurring, it is important to note that if the patient has cumulative consequences of because of that recurring episodes, or they are simply just inconsequential episodic diseases which are happening. This patient had lymphadenopathy and non-healing ulcers, which were considered to be red flags. So the main differentials we were having were, number one, aphthous ulcer major, which is the severe form of recurrent aphthous ulcer. They are larger, deeper, more painful, last longer, and they leave a scar. Then we could have a Behçet's disease, and genital examination would help in those cases, and we can look for genital ulcers, which can aid in the diagnosis. Then we also discussed about lupus and Rowell syndrome. Rowell syndrome is something related to lupus and erythema multiforme. Then we thought that gastrointestinal diseases can also present with oral ulcer, just like inflammatory bowel disease, ulcerative Crohn's disease, or GI histoplasmosis, sarcoidosis, celiac disease. And then we discussed there could be primary dermatologic disease as well, just like pemphigus vulgaris, epidermolysis bullosa. Then we saw that there was mostly surface involvement which was seen, and internal organs were a mystery. We did not know what was happening in the internal organs. So with this predominant apparent mucosal involvement, we thought of Behçet's disease or of another form of vasculitis, which could present like this. So question again was this, that if it is a disease localized to the mucosa, or a systemic disease with prominent mucosal fingerprint. So what the next steps would be to histologically examine the localized lesion and do the radiographic examination of the whole body to see and look for the systemic fingerprint. And then we had the biopsy, which showed ulcerative granulomatous disease. So we thought about Crohn's disease, which can present like this, but fecal calprotectin was negative. Then granulomatous vasculitis can also look like this, but for example, GPA, but the age was not fitting in. Sarcoidosis, non-caseating granulomas could be there, but they don't present in this severe fashion. So we discussed that we should look for reticular endothelial involvement, and we can focus on vasculitis in this case. And there was this term called TUGSC, traumatic ulcerative granuloma with stromal eosinophilia. So we discussed what can cause granuloma with eosinophilia together in one area. So we thought about EGPA, and we have a typical history of allergy or asthma in those cases. And 50% of cases are ANCA negative. Then sarcoidosis, again, we discussed that, and there is something called Melkers and Rosenthal syndrome, which is localized to the mouth. And then we discussed about Langerhans cell histiocytosis, which can also is one of the histocytic disorder, which can present probably like this. And then we discussed about a drug-induced reaction or a potential source of chronic trauma in this patient, which might lead to this presentation, just like as Dr. Ravi said, the braces. And then we saw that the patient had HLA-B51 that was positive, which is strongly associated with an increased risk of developing Behçet's disease. But we discussed it cannot fully explain the whole presentation, and response to treatment would help. Since this was a very exaggerated presentation of the disease, so we can look for some immunodeficiencies or underlying autoinflammatory disorders, which has led to this presentation. And some of the treatment options we discussed were dapsone and DMARD. So ultimately, at the end, we were discussing that it could be possibly Behçet's disease, but it could be also related to inflammatory bowel disease. That because sometimes the disease which we have learned already, they don't, the first manifestations can be different. So this could be a first manifestation of some other systemic disease, which is yet to be discovered. So thank you so much. I learned a lot from the case. Thank you. Have a great day.
Wow, unbelievable. How are you not seasoned R3? I don't understand. You must have done some residency quietly somewhere else. That was outstanding. Well, thank you so much for a great recap. Huge shout out to Dr. Ravi and Dr. Jeffrey for a really, really special day. I look forward to looking back on this VMR 10 years from now when the diagnosis, in retrospect, will hopefully have emerged and a patient will hopefully be doing very well. Thanks, everyone. Bye.